BioBalance Healthcast, episode 167, Anxiety and Hormonal Imbalance.
BioBalance Healthcast features conversations about positive aging. Your hosts are Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging, and Brett Newcomb, a licensed professional counselor.
Welcome to the BioBalance Healthcast. In our last episode, we did something that we like to do occasionally. We always invite you, if you have comments or questions, to contact us directly with those comments and questions, and we'll try to respond to you. And we do respond through emails to all of those that we get. But periodically, we want to take some that are representative of a category of patients that Kathy gets so many people who present this way or have these concerns or these particular questions that are articulated well enough by one of these emails that they can serve as a case example. We're certainly not going to take a podcast for every question that comes in, but when they fall in clusters or identifiable categories, we want to do that. Or if there's something that's truly uniquely unusual, we want to respond to those as well. So we did that in the last podcast, and we're going to do it in today's podcast. We received a letter from a lady named Melissa who articulated a lot of concerns that she had. And Kathy was so touched by what she had to say that she wanted to take this episode to respond. So if you will indulge me for a minute, I'll read parts of the letter that Melissa sent in, and then Kathy will talk about her reaction and response to what she's hearing. This is my last attempt before believing I'm just crazy. In 2012, I started having terrible hot flashes and very heavy periods with large clotting. I went in for an exam and a pap smear. Immediately after my pap, I would have pain during orgasms. My OB suggested Novasure will fix the pain and the periods. I had the procedure December of 2012. I did okay. Exactly when I should have had my period 1 month later, I had panic attacks instead. No eating, no sleeping. This lasted until May 29th when I had a hysterectomy. All gone except for the ovaries. And by the way, that's a controversial topic among gynecologists who perform hysterectomies. Do you take the ovaries every time or do you not? Why would you leave them? What would be the benefit? You can speak to that when you get there. No eating, let's see. My panic attacks went away. They did the pathology. I had necrossing polyp in uterus thermal damage, thermal damage, and post-tubal ligation, ablation syndrome, and pelvic congestion syndrome. That's a mouthful.
Yeah, I'll have to explain.
I did so good in June after my hysterectomy, 7 whole days Ativan free. I cried at night. I was so happy. I was not on any meds. Then I took a turn for bad again. Not panic, but 3 weeks of anxiety, depression, bloating, and then 1 good week. I literally have 1 good week a month, and it's a cycle. I've been diagnosed at the Mayo Clinic with generalized anxiety disorder, cyclic, and also my OB said she thinks I'm anovulatory. I don't get it, nor do I know how to survive like this. I have a prescription for Lupron for 3 months. They say that if I do so much better mentally in menopause, that
they'll take my ovaries.
They'll take my ovaries. I'm desperate for someone who will explain what might have happened to me, why it's cyclic. I started cognitive behavioral therapy. I hope it will help. I've had the best thing that ever happened to me ripped away, the ability to be a good, mentally checked-in mother. I have been to so many doctors that I would be afraid to even make another appointment. Would your office specialize in this, or should I go to a reproductive endocrinologist? So she's really burdened, and she's having panic attacks and anxiety issues. She's doubting her own mental stability. She's not finding answers from multiple doctors and clinics that she's been to. And your thoughts are that all of the descriptors that she puts in her email tend to fall in the categories of anxiety and hormonal imbalances.
Yes.
And so you want to speak specifically to those things.
And that's one of the things. We've talked about anxiety and hormonal imbalances before, but there's a couple things that need to be addressed here. And one is that sometimes when we do hysterectomies, we just take the blood flow to the uterus, but sometimes the blood flow to the ovaries, which is where our hormones are from, is compromised at some point. Therefore, sometimes the ovaries don't work as well or go into menopause earlier than they might if they'd been left alone. Now, she clearly needed a hysterectomy for bleeding and for pain. So I mean, this doctor seems like he was working with absolutely everything he had to try to make her better.
Right.
However, an unintended outcome of doing a hysterectomy that he thought would be curable, or she thought would be curable, I'm not sure if it was a he or she, but is sometimes that the ovaries don't function as well. Now, what she describes, the 3 weeks of feeling terrible and 1 week feeling better, is a PMS description. What that would say to me is the one thing the ovary is still making is estrogen.
Okay.
Because estrogen is usually in PMS. We talked about that last time. When someone has PMS, they have an elevated estrogen and no progesterone to balance. Usually it's like this, but the progesterone is very low, so patients feel anxious from high estrogen. So
Okay.
it could be that. That's one possibility. I don't have enough lab to tell if that's the case. And in that case, Lupron might help because that would stop all the hormones and then they take your ovaries out. But I think there's another component. Oftentimes we don't feel PMS from high estrogen and low progesterone. We have that periodically through our lives, but we don't feel it early on because we got plenty of testosterone. Testosterone's a buffer. Testosterone takes away the sting of PMS and makes us much more normal. So I would guess, because I don't know for sure, that her testosterone has been gone for a while, and that's why she was having some anxiety issues. Her progesterone's been gone, which is one of the sources of the severe bleeding, besides the polyp, is when the estrogen is elevated and there's no progesterone. And she still has ovaries that are still making estrogen, and it's an imbalance. So before doing something like Lupron, which would take away all her hormones, and if it's related to testosterone, would make it worse. It would take that little bit of testosterone that she has and make it even lower. I would try replacement of systemic testosterone to see if you can buffer this reaction until she hits menopause without having to go through yet another surgery. When I had my ovaries out, I had terrible migraines. I had all the symptoms that I have on our questionnaire, basically everything before, and they were worse after I had my ovaries out. And I thought, they'll be better. My migraines will be better. They were worse because my buffer system, my testosterone was gone. I had made just a tiny bit, just enough to keep me from being 100% miserable. When my ovaries were gone, I was worse. So I don't want to suggest that you go through that before trying testosterone replacement. And there's no other way to test it, really, is for you to have your testosterone level tested and then find a doctor willing to replace testosterone so that you can get your total testosterone above 30. That's the key.
So she says in her email that she's 36.
Yeah.
Is that within the range typically of people losing their testosterone?
It's early.
Or having it?
It's early, but most people don't have any
all these other complications
of these things going on. So her ovaries were probably a little bit malfunctioning just earlier than other people. It's genetic, or it's stress, or it's just a hormone imbalance that inherited or stress related.
Yeah.
So toxins, nutrients,
Sure.
Things like that. So all of these things in our environment affect it. I can't tell you one thing that would cause it, but we know that people do this early. I mean, my migraines started at 37, 38, so I was already experiencing a testosterone loss, and now, and ever since I've had testosterone, they're gone. So for her symptoms of anxiety, I would suggest getting her lab tested to see what her estrogen is, what her progesterone is, what her testosterone is, and her FSH and LH to see where they are. Is she in menopause, or is she still cycling? Is she still making estrogen? But the reason it's cyclic is partially because it's too much estrogen. The progesterone is not being produced from day 14 through 28. That's what your doctor said. Anovulatory means no progesterone, which to me means PMS if you've got plenty of estrogen.
Right.
Now, testosterone, I believe, would buffer this and take away your anxiety. It has in many of my patients, and I've been very happy with that. Another reason, just for everybody else, to have anxiety when you're going through this, say, 40-something in most people, is that when your FSH and LH surge, she said she had hot flashes. That could be from low testosterone or low estrogen. Those surges destabilize your brain. And when they destabilize your neurotransmitters, we either feel anxious or we feel depressed, or we feel irritable. All of those things are from our hormones or the lack of them causing us to have a disrupted brain homeostasis. So that's what that could be. Say we did her lab and she had no estrogen and she had no testosterone and no progesterone. Her ovaries had already gone through menopause. Then basically her FSH and LH surges were trying to push her ovaries into making those estrogen and testosterone. That would destabilize her brain and make her anxious all the time.
It's also on that fuzzy line between physiological and psychological. All the things that Kathy's saying about making the physiological changes may be a sufficient thing to do to make the anxiety go away and not come back. But there's also the potential, if you've suffered from anxiety for a long time, that you've learned certain patterns of hypervigilant and thought escalation that will get in your way. And so the cognitive therapy is a strategy that I would recommend that you continue no matter what you do, because you need to learn the techniques of thought stopping and thought regulation. You need to work on some reality testing scripts to test the source of your anxiety, like if you have a phobic reaction to snakes or something, to be able to say, there aren't any snakes here. I just saw one on television, but that's through the TV, and I'm not, in danger. And there's a methodology for regulating your thoughts that decreases the surge of anxiety. So I would say it's a two-pronged attack. One is to do the medical interventions that you're talking about, which may make the issue go away. But if you've habituated your thought processes and your reaction processes, you're going to have to retrain them. And the cognitive therapy will help you do that.
What if most of my patients, I ask my patients what they're anxious about.
Yeah.
And generally,
generalized anxiety means they don't know.
They don't know.
They just feel a level of hypervigilance. They feel a level of awareness. They're waiting for the other shoe to fall. They're nervous. They don't breathe deeply. I mean, there's a lot of stuff that they can work on that could be helpful if they teach themselves to do it.
Okay. I was just thinking of the anxiety that is overwhelming. Most of the patients say then if one more thing happens, I'm fine. I'm holding it down. I've done this.
I'm white knuckling my way through life.
I've calmed myself down so that I don't have bad behavior in front of my children, my boss, my husband, and then all of a sudden one more thing happens, and then I lash out, and that's probably common in people you talk to.
What's the kind of stuff that happens in road rage?
Yeah.
I'm fine. I'm going to kill you. Literally, get out of my way.
Right, and so I hear this a lot, and I hear that basically testosterone's the key. Sometimes it's estrogen, sometimes I have to replace both. But in this instance, I believe that she probably still has some estrogen. So I believe that overwhelming just anxiety when I wake up, anxiety when I go to sleep, and that one thing that can cause you to just lose it, kind of anxiety, and I don't have a name for that. I guess I'd call it hormone loss anxiety. That the FSH and the LH are surging all the time, and then they just need one little disruption to go over the top.
Okay, why are they surging?
They're surging because the ovary's not making the hormones it should. So the brain is making FSH and LH to push the ovaries to make estrogen and testosterone. And it's that elevated level of FSH and LH are causing destabilization in the brain and making it irritable and unpredictable. So those surges do that. Some people get hot flashes, some people get anxiety, some people get both. And usually the people that have this from FSH and LH surges and not from PMS get it more at night than they do during the day. So that's one of the things I ask people to see if I can, basically by history, locate.
Are you more anxious at night? Are you able to sleep?
Or do you wake up with anxiety attacks and sweating and worrying? That's often from a surge of FSH and LH from lack of estrogen and testosterone. So those are the people that I deal with, and those are people that get better. Also the people that have PMS kind of symptoms, and they can't tell because they don't have a uterus. Those patients get better with both testosterone and progesterone.
That's so fascinating, because what I was trained to do about anxiety attacks and panic attacks and how to understand them and how to frame a conversation about them. Didn't include any of that physiological stuff that you know.